growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, I'm Dr. Steve Rasner, and welcome to another episode of The Lionhearted Dentist. Last week, I sidetracked a little bit and tried to remind you of why you're doing all you're doing. This week, I'm going to get right into, after my brief introduction, I'm going to get right into some clinical tips during case presentation. I've alluded to these before, but I want to be crystal clear with you today because I think they make such a difference in case acceptance. Finishing that thought, I told you, listen, you have to be relentless if you want to be successful. I truly believe that. I mean, it's a Saturday morning today. I'm in mid-October. And, you know, I had a pretty hard week. And part of my weekend is dedicated to looking up in one of my textbooks something that I had down that I want to make sure I have it down clinically the way I'm doing it. Maybe going on social media and looking at some video. Seems pretty weird. I'm also playing tennis today. And I worked out yesterday in a gym. So yeah, I mix it up. But, you know, getting to the place you want to be, it just never is handed to you. So that's why I took a podcast out to remind you about, do you care enough? Are you willing to do more than you're doing now? You can never be complacent, meaning even if you're at a good place in your practice professionally and personally, you just never can be complacent. You always have to step back and evaluate, am I doing the best I can? Arriving at a place of huge achievement in life, it's just not by accident. So that's why I tell you those things. And again, thank you to everybody that keeps listening. So let me get to a couple clinical tips that I think can have an immediate impact. I want you to listen to me. First of all, what I want you to do right now is I want you to picture in your head what your case presentation looks like. And I mean every step. By the time that you go in and you're actually going to speak on what that patient, what your recommendations are, what does that look like in every way? What were the steps to get to that point? Think about it. Think about it right now. What does it look like visually? Is it on the first day? Is it after several or more than one visit? Sometimes you do indeed have to bring patients back if you're not clear on day one. And I will tell you that as you practice longer, if you're really a student of dentistry, you become less vulnerable to poor decision making in treatment planning because you have this wealth of history behind you. And, you know, a lot of times you can make day one treatment recommendations that you may not have been able to make earlier in your career. But I want to talk specifically, and I know that I've touched on this early in the podcast development, about the patient with a potentially terminal dentition. I'm going to give you two killer case presentation tips today that lead to crystal clear communication with your patient, and because of that, case acceptance. So, but you have to begin, you just can't walk into case presentation with what I'm about to offer you. You have to have a process to it, starting with the branding in either print media, on your website, on social media, on the radio like I do, that you stand for trust and confidence. And let me just say it, man. That they can trust you, that you're not there to rip them off. Don't think that some of your colleagues go that way. I'm sorry, they do. Or that they make Hail Mary treatment plans. They do a 5-unit bridge would be an example to me, from a third molar or second molar with 3 ponics and with an end abutment of a cuspid. Yeah, will they walk out of your office the day you cement that in and be okay with it? Yeah, they will do that day. And then they'll be back within a short amount of time, too short of amount of time, with recurrent decay, the need for endodontics, some type of failure. And that failure started with you. And that is what I mean when I talk about confidence and trust, that they can trust you. The patient doesn't know that a 3-ponic or a 2-ponic bridge is a recipe for failure, or that you ask an implants to do more than they can do as well. I mean, we could go on and on. But before I get off on one of my famous tangents, let me reel myself back in and talk about the first treatment planning pearl to help you communicate. And that is, you need this week to get a model of an edentulous arch, upper and lower, articulated, and I want it to be Pete Dawson clean. Meaning, go back, and Pete Dawson used to say, sloppy models are not an indication of sloppy clinical dentistry. They're absolute proof. Okay? And when you go through his courses, when he was giving them, his models were impeccable. So this model wants to be a model that looks like somebody spent a lot of time with the plaster work. It has to be beautiful. And the ridges have to be beautiful. And then I also want you to have, for those ridges, a full upper and a full lower denture. So that is literally, I've talked to you about having models before, but I never talked that clearly about it. Now, I don't know whether you can just purchase those, by the way. Next time that you do a denture, that's what you need to do. You need to tell your lab, or if you do it yourself, to replicate the master model. And when you get to the bite-centric bite record portion of the denture, and I'm specifically using a full denture for a reason, everything's got to be articulated, and then the final dentures have to be duplicated as well. It will pay you 1,000 times over, by the way. So don't let cost prevent this. I don't know whether you can buy that online. I don't think you can. And of course, I have 3 boxes of models, and they relate to the different types of restorative. And by the way, it took years to acquire them. You'll just start out with very little, and as time progresses, some of these things you can purchase, certainly implant models. But things happen in a career that, for whatever reason, you're going to end up with models for patients' work that was never delivered, and that's really a lot of what I use many years later. But let me take you back to the denture. So when you get that patient in your chair that believes that they're going to lose multiple teeth, having a denture there for the reason of really crystallizing in their mind what a denture is going to be like, or maybe not now, but even later. So it brings up it motivates them to do what you're recommending so they don't end up with a denture. Now, sometimes it's just a terminal denture patient that it's too late. That is where they're going to go. And the purpose of those models is for clarity. I mean, I'm going to tell you exactly how I do it in a minute. And really giving you a basis to speak about the alternative, which is implant dentistry. And I think we're past the point as colleagues where this is a sales tactic. It's truth tactic. Who in their right mind would be able to get on a podcast these days and say, lower dentures are just fine? I'll tell you something to my younger colleagues listening. In the older days, you would led to believe that your technique just wasn't good. And that probably was true for some of us. But with the best technique, with Joe Massad teaching the technique, it's a lower stinking denture. Let's be clear. I understand that you can make an acceptable, functional, to some degree, maxillary denture. But in my opinion, with the exceptions of the few people I've seen in my career, lower dentures became a complete nightmare for most patients. So it's not just talking about implant therapy as an alternative to full conventional dentures. It's recommending that this patient, if it in fact is applicable, should fight to keep the teeth they have to prevent them from ever getting in that decision tree. You hear me? Can you feel that? I mean, that is an important thing. And I am just so comfortable. When I first used that model, it was just to talk as a launching point for the alternative of implant retained prostheses. You know, you got to stop for a minute and understand the net outcome of what I'm saying. We've had 3 weeks in a row over 6-digit collections in my office. And full disclosure, I have 2 offices that account for that, but the one office accounts for way less than 25% of all revenue. So even if it was just my violin office, if it's a $100,000 a week, we're talking 75,000 of it or more, way more usually, came out of one office. That happens because of what I'm telling you right now, of the smooth flow of communication from me to a patient and their spouse, which is it's often usually in the operatory as well when we get to this point. No pressure. You heard me mention last week that the more that you communicate, the less the thought of, the pressure shouldn't even be in the equation. I don't want, and I am against, to be clear, sales tactics. And I've been in lectures where I've heard pretty prominent speakers in our profession talk about what to do if the patient says this. Are you kidding me? I am so against that. I mean, I think it is important to understand the psychology of communication with a patient. Are you dealing with one of the 4 personality types? That works in anything in life, not just in case presentation. If you're dealing with a socializer, a driver, a relator, or a thinker, there are 4 distinct personality types, sometimes referred as similar names than what I just said. I said a socializer, driver, thinker, and relator. They are the 4 personality types that you and I have, and that everybody that you know has. And if you want to get a point across, you indeed deal with those personalities differently. You already do it, and you just don't know that you're doing it. And so, yeah, that I think is fair game. But bringing in the psychology of sales beyond that, to me, is no part of what I'm trying to deliver to you. And I actually feel so confident about that when I'm speaking to the patient at that moment, I even bring that up. I even hear myself saying, hey, listen, let me just make this clear. This is a big decision. And I don't at any point want you to think I'm talking you into something. Here's what I am doing. I don't expect, even though that most people know visually to some degree what a denture is, they've never held it in their hand. So do you realize that if in fact you go from what you have right now, Mrs. Smith, to a full denture that is one of the options, that it's going to cover the roof of your mouth. So let me just give you this for a second. And at that point, she's holding this denture in her hand, and I have the maxillary model of the articulator off, and I'm showing her. So I point out that it covers the roof of your mouth, which has a couple negative consequences. If you're a gagger, it's obviously a significant consequence. And then secondly, it affects your taste. And I'll often say at that point, I want you to think for just in a minute about eating ice cream or a potato chip or anything. Part in your mind right now when you're thinking of that is the sensation of whatever you're eating against the roof of your mouth. And then I'll say this all the time. And I'm not saying that there aren't millions of people around the world that have become accustomed to that and have gotten used to wearing a full prosthesis. I'm just saying that if I can prevent you from ever getting anywhere near that zip code, then I think I'm doing you a good service. This is how these talks go. So that patient that I'm speaking to at this point may have a bunch of teeth in her mouth. And maybe the therapy is quadrant scaling and root planing. And maybe they are even going to lose a couple teeth, or we're not going to know until we get through the therapy. In my office, that may include periodontal surgery, open flap curettage, deep home care, the maintenance every 3 months. And you see what's happening is that patient that I'm referring to right now becomes a percentage of the patients in my practice that may not ever have implants, but they are in a 3-month recall program that they're inspired to do because of what the conversation that I took the time to have with them. And it's coming from in my soul and heart, like it should yours, of passion, because I do think that many of us just never really think about what it must be like to wear a full prosthesis, not the least of which is you lose 70% of the functionality of your chewing power as well. I don't think it's an accident that full denture patients have significantly higher GI problems than non-denture patients. So when you believe that passionately about not wanting a patient to ever even get in that zip code, a lot of treatment sequelae that can come way before having to make that decision seem to be relevant all of a sudden. Even the concept of coming in every 3 or 4 months, and you better believe that I say to that patient, and let me tell you something, this is what I say when I talk about 3 or 4 month recall. I say, that 3 or 4 months is going to come up so soon in your mind that you're not going to believe that you're really due in my office again. And guess what? It's even worse than that. Insurance isn't going to cover that for you. So I said, but let's look at the other side. Maybe we're never having this conversation right now. That denture model doesn't just apply to the terminal dentition patient. It applies to a patient with moderate perio. Or maybe a patient that is going to lose multiple teeth, and for now, a partial denture, which I'm not a big fan of, becomes something they have to wear. And then the maintenance of their teeth that they are keeping becomes even more extreme and important. So to me, even as I'm telling you this and sharing with you this, I can picture myself in the operatory and the passion I'm delivering. These patients can feel it. They can see it in you if you do this, if you believe in this. And we haven't even gotten to the lower denture yet. We haven't even talked about that yet. So I could be talking to a patient that maybe wanted to extract a tooth that could have been saved, a molar, let's say, with a root canal. And I'm looking at that tooth at this stage of their dental journey as an abutment that's important to keep. So how are we going to keep it? Well, and is it worth keeping? Well, for one thing, it requires a root canal and maybe a crown to keep. I'm talking about a tooth that doesn't have a furcation yet. Or maybe it has a FERC class 1, early on. And I consider it an important abutment at this stage. I don't know. It's not fair for me to espouse my opinion on it. I don't know clearly the philosophy of all-on-4 clinics, clear choice, and things like that. But I know a lot of them take dentitions. I know this is a fact. Maybe like I'm alluding to, and think of the inevitable and get it over with, so to speak, and get the patients into a 4 to 6 maxillary implant retained prostheses. No, man, I want them to have their teeth. I still believe old school periodontal therapy can work years and years for patients because I have too many as examples, and I know you do too. So I don't go to that if there's other options on the table. And let's talk for just a minute. Let me see where my time is here. Well, I'm going to come back to this topic for the lower with the next podcast, but I do want to give you one more clinical tip that's got nothing to do with this, that's maybe overlooked by a lot of you. And I'm giving it to you because it's a great way to do the proper clinical dentistry and gives you greater case acceptance and expands your case a little bit. So I'll come back to that. But remember my takeaway here. You need to get a denture. Look, I've never duplicated what I have. And maybe I could do that for some of you if you write to me. I wouldn't even think of making a lot of money off it, if it'd be even worth it for me to do it. But I do have the perfect model. I mean, it's just perfect. And I just find it, I know I'm being redundant, but I just find it in my room to be more applicable to just that patient that's at the end of their teeth. It can be used way before that ever happens to motivate patients to keep teeth and to aspire to comprehensive dentistry to avoid that. So we'll leave that on the maxillary today. So the second clinical pearl here for case acceptance that I want to tell you is that the next time that you're treatment planning a single crown, either on a tooth or on an implant, be sure to stop for a second and look at the adjacent teeth contours. Are they ideal, or are they perhaps concave and going to set you up for a food trap? And it could even be a filling, or it could even be a crown. And I will tell you that I treatment plan that as part of the treatment plan. It may necessitate 2 crowns, not 1. Because if you don't do that, your new crown is going to be causing the food trap that they now have. You hear me? Or the concave composite restoration on the adjacent teeth, or maybe it's too flat to create an ideal contour. I know that's minutia, but I have to tell you that I've been caught with it too many times that for years now, I just automatically look at the adjacent teeth and make that part of the restoration, part of the treatment plan. Anyway, I know I don't do much clinical with you guys, and not that this was so clinical, but with the talking about the models and all, and I hope you understand how compelling having that model is to a lot of your treatment recommendations. But we'll pick up on that next week. Hope you're having a good fall in your practices, as in the season, the fall. And I hope you continue to tune in to the Lionhearted Dentist. I'll see you next week. Stay strong.